Hi, everybody, and welcome as people are getting on. It's noon. Welcome to the Medical Biochemical Genetics Clinical Course Seminar Series. This is week 10. We're going to be talking with Dr. ElGharbawy from Duke about carbohydrate metabolism, covering things like galactosemia, hereditary fructose intolerance, the pentose phosphate pathways, so glycolysis, gluconeogenesis. Lots of good things coming up. Thank you for joining us live. If you're here, I know this week may be a little bit depleted in terms of live interaction just because of the urea cycle consortium. So anybody who's watching this asynchronously or recorded on the SIMD website, welcome. And I hope you enjoyed that conference too. I've heard it's awesome. And so yeah, thank you for joining us. Next week, just as a heads up, we'll have Dr. Wilcox talking from Emory about lysosomal storage disorders. And this week, for questions, if you can put them in the chat, that would be good. We can save them to the end. Yeah, with that, I think I'll give it to Dr. ElGharbawy. Take it away, Rig. Thank you.
Yeah, thank you. So thank you. And let's see now if my slides suddenly don't want to advance. There we are. So today I am going to cover a lot of topics, and just to give you heads up about what we're going through. So I've talked about glycogen storage diseases in part 1. And today I'm going to focus on some of the so-called, again, it's in the table of glycogen storage disease, but they're also considered mainly glycolysis defects. I'm going to focus on the ones, these are all very rare, by the way, but I'm going to focus on the ones that either have something to it or they're a bit more common than the very rare ones. But I'm also going to talk about pyruvate dehydrogenase deficiency in more details, as well as talking about gluconeogenesis defects, including pyruvate carboxylase in this case with details. Part of gluconeogenesis and is the fructose pathway. It kind of goes into that part as well. So I will talk about fructose metabolism with the disorders associated with that, as well as galactose metabolism and galactosemia and the group of galactose disorders are ones that we always encounter. So it's important to go through them with more details. And then at the end, another one of the rare groups of disorders, but a group of disorder of its own. And we don't usually encounter it, but we should be thinking of it, especially in patients with liver disease and so forth. So that's the pentose phosphate pathway. So I just want to say again, the carbohydrate metabolism is all coordinated. I mean, the different pathways work in a way where you either have, again, glycogenolysis or glycogenesis. So when you're forming or you're synthesizing glycogen, glycogenolysis is not active. The enzymes that are involved with glycogenesis, we spoke about one of them, which was glycogen synthase. Today, I'm just going to mention a bit about glycogenin, which is one of the less, again, you may be less familiar with it, and it's rare, but it is a condition associated with mutations that lead to a clinical phenotype. So I'll talk about that. For the glycogenolysis and the glycolysis part. So glycogenolysis is, of course, breakdown of glycogen into sugar, but then the glycolysis is oxidation of the sugar. And that pathway is one that involves multiple enzymes. We've spoken about some of them when we were talking about glycogen storage disease. I'm going to talk about a group of others of them as we go down the pathway. And these are separate, so they're different than the muscle, for example, GSD types and so forth, but they are associated with muscle disease. And because the red blood cell does not have mitochondria, RBCs are dependent on glucose metabolism. So you're going to see that there's a phenotype where there's hemolysis involved in these disorders. So keep an eye on that. And then at the end of glycolysis down here, you end up with pyruvate. So we have two pyruvate or congenital disorders associated with lactic acidosis and pyruvate metabolism. So I'm going to go through the pyruvate carboxylase and pyruvate dehydrogenase from that end. And then the pentose shunt, which is the PP shunt, which we're going to talk about the transaldolase mutations and so forth. So I want to say all of these pathways are interacting one at a time, or sometimes there's an interaction where you have, again, all of them entering at the end to make energy and restore energy, if I could put it that way, so that the Krebs cycle can keep on moving forward with, producing ATP. So just to show you where these enzymes are, so I'm going to talk about glycogenin. So that's going to be in one of the, again, start of gluconeogenesis pathways defects. And I just want to show you where it is, because I will show it to you in a table later. So it's right up there. It's with the synthesis of glycogen. And I want to just say it is the beginning part of synthesizing glycogen, meaning you have to have that unit of carbohydrates that is forming together, and then it gets some energy from UDP, and that's where glycogen synthase starts adding, more of the glycogen to it. So I just want to say that start of glycogen synthesis happens with glycogenin, and there are different forms of it, one that is in the muscle and one that is in the liver. So the idea is you will have a phenotype based on where the defect is. I'm going to talk about, going down this pathway, the different mutations that are associated with rhabdomyolysis and muscle disease, as well as hemolytic anemia. So I'm going to talk about, if you can see my arrow going down here, the phosphoglycerate mutase. I'm not going to talk about enolase, but there is a similar condition where you can have rhabdo and muscle weakness with enolase. I am going to talk about the phosphoglucose isomerase and the mutase. So those are the ones that I will be talking about today. And then, of course, aldolase, I will be talking about that as well. So let's just go and start where we could, get more informed about the less common types of glycolysis defects in GSDs. So GSD type 10 is the muscle phosphoglycerate mutase deficiency, PGAM, and I can go again. The type 10 is where the, I said the glycerate mutase, so it's right here, okay? So there is where it is in the glycolysis pathway, and a mutation in that part. I just want to say that the classification of the GSDs has changed over time. If you recall, type 11 used to be Fanconi Bickel. It's not, it's lactate dehydrogenase right now. So if you haven't updated your, experience and knowledge about the classification of GSD, it's a good way to, or a good place to start doing that is the Annals of Translation of Medicine. It does have the updated one. It's from 2018, but there are others as well. So anyway, the gene defect is in the PGAM2. There's only about 15 cases reported, but that was back in 2018. And I just want to say it is associated with exercise-induced muscle cramps and pain. You can have exercise intolerance, rhabdomyoglobinuria, again, muscle-induced hyperuricemia. And these patients sometimes, or some have had arteriosclerosis, but I don't think, or I don't know that it's associated with the phenotype in particular, and it can happen in childhood or adolescence. Why am I mentioning this? Because these are the disorders where sometimes when you don't think of them, and if you don't have a panel that includes them, may get missed unless they got picked up by whole exome or a panel that includes all these genes. So when you're looking at a patient who has rhabdo or exercise intolerance, and you see that the panel that you sent does not include these genes, it means that there are still some conditions that you may have missed by not testing for them, okay? Another one is GSD11, so the true GSD11 right now, which is lactate dehydrogenase deficiency. And this is lactate dehydrogenase A deficiency. So it also is associated with the exercise-induced cramps and muscles and rhabdo and myoglobinuria. And they can have some problems with uterine contractions during pregnancy. And then there's GSD type 12, which is the fructose 1,6-bisphosphatase aldolase. So where are those on the chart again? So you can see here going down. Let's see. Just want to show you. Oops, sorry. So this is lactate dehydrogenase, so that's not the one. I'm just hoping that I have it here. No, I had it here somewhere. Anyway. I apologize for that. So it's on the table, let me put it that way. But just to keep on track, the lactate dehydrogenase A abnormality is one again of the rare ones, and there's hardly any cases reported. For the fructose 1,6-bisphosphatase aldolase type 1 or type A, it's also one that affects the red cell phenotype. So you can see that they can have short stature, myopathy, some changes in terms of intellectual disabilities. And I could tell you right now, whether the disorders are associated, again, the intellectual disability and so forth, because these are case reports that are very rare, how they are associated with these risks are ones that we're still not knowing too much of. We do understand the hemolytic part. We do understand the muscle part, the rhabdo and the muscle. The dysmorphic features, again, are some things that we have to learn more about. Because these are rare cases, they've been reported, but the exact etiology of how these things are happening are things that we have to learn more about as we see more of these cases. For GSD14, I'm going to talk about it a little bit more in details other than what's here on the table. This is an important one to know because there's a treatment associated with it that's special. So phosphoglucomutase, and that I can show you here. Right here is an important enzyme because of what it does. So first, it's considered in glycogen metabolism, glycolysis, as well as protein glycosylation. So it is actually classified as a glycolytic disorder, a GSD, but also classified as a congenital disorder of glycosylation. And to be exact, it's CDG type 1T. And because of that CDG part, and because it has treatment, it is important to keep that one in mind because you don't want to miss it if there's a treatment. So treatable conditions are ones that you never want to miss, and you have to think of them to be able to, to know them and look for them and diagnose them. So these patients are really specific. So yes, they have an explained phenotype. Short stature, cleft palate, bifid uvula, they can have Pierre-Robin sequence, and then they can have evidence of multi-system disorders, specifically liver disease, dilated cardiomyopathy. They can also have hypoglycemia and exercise intolerance. So the spectrum is quite broad, one that involves muscle phenotype, which can be only on the muscle phenotype, and that makes it more towards the glycolysis, glycogen metabolism, or actually, it can be more of a multi-system associated with dysmorphic features, and that puts the CDG part. Do they both respond to the treatment? Likely, and I'll talk about that, as I said, in a coming slide. The glycogenin, which is the one that I was mentioning about, is considered GSD15. And this is a condition where, as I said, it's on the top here. It's associated with the beginning of the synthesis of glycogen. And without it, you wouldn't have glycogen. So it's important for where it is and what it does. And here in the table, they talk about the muscle type. So the muscle type is associated with muscle weakness and cardiac arrhythmias. And of course, there's an important part, which is in the liver as well. We always used to hear about Fanconi-Bickel being type 11, and as I mentioned, it's not type 11. It's not even a GSD. It's not a glycogen storage disorder. It's basically a glucose transport defect, and the glucose transport defect is one that involves glucose and galactose. So these patients will have significant renal tubular acidosis associated with aminoaciduria. They can have, of course, phosphaturia, and calcium can be lost in urine. I just want to say, if you have any patients with these disorders, they also, because this is a proximal renal tubular defect, they also have carnitine loss in the urine, and they have muscle weakness, and it improves when you do give them the carnitine. I've been, lucky to have two patients that, although they were older, 9 and 11 years old, and totally debilitated, when they came to me, they had all the rachitic manifestations that you can think of. So, when you think about a patient that has renal tubular acidosis and is losing phosphorus and calcium, they have severe rickets. I mean, you could look at their ends of the long bones, and you can see the, the rachitic manifestations uh, really significant in the x-rays, but also even that Harrison sulcus and all those pigeon chests and all the bowing of the legs, all of that there. And then you start them on treatment, so you replete their needs in terms of the phosphorus, calcium, magnesium. So you have to have nephrology with you. You have to have endocrine with you, because they tend to have responses to vitamin D. They need the 125 hydroxy vitamin D replacement. And you need, of course, the biochemical geneticist who's going to be able to work with a dietitian and the patient to make sure that these patients are on a galactose-free diet. And they can do okay with fructose, but we don't like to give them simple sugars. I just want to say, with treatment, these patients do well. So my two patients, despite I got them at a later age, they were able to ambulate after being totally, I could say wheelchair bound, because they couldn't even stand on their feet. And one had even corrective surgery, and you wouldn't know it necessarily, but he's very short, so you may pick it up from that. But that's what I'm trying to say, is these patients are treatable once you diagnose them and you start the treatment and you control, the problems that they have. So they have ketotic hypoglycemia. They have problems with lactic acidosis at times if they eat much. And remember, so this is a glucose galactose transporter defect. So the problem with the galactose is that it doesn't get handled well. But the problem with the glucose is once they eat, if they eat too much carbs, they can develop postprandial hyperglycemia. And you can see blood sugars that go up and down, and they just swing, because if they peak so high, insulin's going to come up and bring them down. So these are patients that benefit from a Dexcom being there, and then at the same time making sure that the diet has complex carbs, but what we call the low glycemic index carbs, so that they don't swing up and down. And then we're going to go to the, as I mentioned, GSD14, or the phosphoglucomutase deficiency, which is now a CDG, or classified as one of the CDGs. So the idea about this is that, as I said, it's a center to glycogen metabolism, glycolysis, and protein glycosylation, specifically N-glycosylation, just to make that clear. You can pick up the gene if you did a panel for CDG, but also if you did whole exome sequencing, and it can come up through that. It's not one of the disorders that you think of that much, but if you see the clinical features, so again, because the spectrum is broad, you might not see the dysmorphic features, but if you have evidence of a muscle weakness and myopathy, and it's not on the panel that you sent out for, look for it, because this one is treatable. And if you have the features, think of it, and especially if you've got the cleft palate with muscle weakness or muscle pains or liver disease, that type of combination, think of it that way. I want to say that the cleft palate is one of the most malformations or commonest malformations in this disorder, followed by the bifiduvula, and Pierre-Robin sequence is the last one in terms of the abnormal features in the face and in the tongue palate area. But then remember that they also can have dilated cardiomyopathy, and that they can have hepatitis, and that has to be kept in mind. So looking for the liver function. So here are the most common clinical and laboratory findings in the PGM1 CDG. You can see here the percentage of the cases that have been looked at. And this paper is a very important one, because it's like the international consensus, which has the diagnosis as well as the classification of the disorder and the management of the condition. So this is a good consensus paper to have if you ever have a case of PGM1 CDG. So the treatment is D-galactose, and galactose is again a monosaccharide that can restore the glycosylation, basically by replenishing the depleted pools of the UDP glucose and the UDP galactose, which are necessary for N-glycosylation. And that can improve several of the symptoms. Does it cure the disease? No. Does it cure everything? No, but it may improve the labs, and it may improve some aspects of the disease disorder. And it could improve the muscle weakness and so forth. So D-galactose in the trials that were done, in the clinical trials that were done, is between the dose is between 0.5 to 3 grams. Given the fact that 3 grams per kilogram, just given the fact that these again are monosaccharide type of carbohydrates, you worry about side effects as diarrhea if it's too much. And although the clinical trials suggested that there were not too many adverse events, there were some patients who could not tolerate such a high dose. And in that case, you would modify the dose to a lower one. And for that patient, they provided a 0.3 grams, so lower than what was recommended before. So you always have to, again, make sure that you remember that this is a monosaccharide and it's a sugar. So sometimes it can lead to intolerance, and you have to, based on that, modify the therapy. And Dr. Eva Morava's group is one of the, she's at Mayo now, so she's one of the people that if you have questions, you probably should ask her, and she can help with that. The treatment alleviates, as I mentioned, some of the symptoms, but it's not perfect and requires a metabolic dietitian to maintain the dietary needs. So you can imagine that, again, you're adding a monosaccharide to a patient that has a disorder, and part of the treatment of this disorder is carbohydrates. So you have to make sure that the dietitian is maintaining the needs from all proportions, giving proteins as needed, and then making sure that the amount of carbohydrates that are there are sufficient enough to treat the disease without having side effects. And then I'm going to move towards at the end of glycolysis. So down underneath. So at the end of glycolysis here, you have pyruvate, and that's important because that pyruvate is going to have to change into substrates that are going to go into the mitochondria as acetyl-CoA, and then that's going to happen through pyruvate dehydrogenase or into the Krebs cycle through the avenue of oxaloacetate, which is going to happen through pyruvate carboxylase. So always remember, pyruvate will change into acetyl-CoA through dehydrogenase and to oxaloacetate through pyruvate carboxylase. So pyruvate dehydrogenase is the rate-limiting step for glycolysis, and PDH complex contains 3 enzymes. The one that you want to remember that's very common is the E1 pyruvate dehydrogenase, and that's an alpha 2B2 heterotetramer. It leads to irreversible oxidative decarboxylation of pyruvate to acetyl-CoA. That acetyl-CoA is very important because it's associated again with driving energy into the mitochondria and with synthesis of the lipids and so forth. So it precedes entry of glucose carbon into the Krebs cycle. And then it's important for aerobic glycolysis, especially in the brain. And it's an obligatory pathway for that reason. So it's important for energy generation. So you can think of it this way, is if it's necessary for the brain, then the brain and its need for demand of energy is going to be affected if you have a mutation that involves pyruvate dehydrogenase. And we all know if you've had a patient with pyruvate dehydrogenase, how significant they can have symptoms. I mean, it's one of the most common conditions associated with Leigh syndrome. And I'll never forget when we had a case that had a severe influenza virus, and I went to talk to the radiologist about what did the MRI look like. He said, it's a sad MRI. And I said, what's going on? And he said, the infarcts are all over the place. So that tells you how bad of a disease it is. So the most common form is caused by mutations in the X-linked E1 alpha gene. Other causes are due to alterations in, other recessive genes, because there's 3 types. So which are these other types? So there's the E2, which is the dihydrolipoyl transacetylase, or DLAT, form of pyruvate dehydrogenase, again, less common than the X-linked form. And it is autosomal recessive. And just to know, the dihydrolipoyl transacetylase, or DLAT, forms the structural core and accepts the acetyl groups from the E1 and transfers them to the coenzyme A. I want to say that there's a 3rd type, which is also known but less common, and it's the dihydrolipoyl dehydrogenase. And that one is active in the branched chain keto acid dehydrogenase and alpha ketoglutarate dehydrogenase complexes. So you can think about it just from thinking of, the fact that it's associated with branched chains and with alpha ketoglutarate, that the metabolism or the metabolites associated with this disorder are going to involve those two pathways. Okay. And then we have the E3 binding protein, which is protein X, and that's involved in the interaction between the E2 and the E3 subunits. So the diseases that are associated with the disorders will happen with, pyruvate dehydrogenase, the DLAT, and the DLD type. I don't know of one that's associated with the binding protein. It's important to remember for anyone who's doing biochemical genetics that the PDH complex requires 5 different prosthetic groups and coenzymes. So just to keep that in mind for the PDH, the type 1, or I would say the E1 alpha, it requires the thiamine pyrophosphate. For the DLAT, it requires the lipoic acid as well as the coenzyme A. And then for the DLD, it requires the riboflavin or the flavin adenine dinucleotide, which is riboflavin, and the nicotine adenine, the NAD, nicotine adenine dinucleotide. So for PDH deficiency, the E1 alpha subunit is X-linked. It's on the X short arm, and thiamine is the cofactor that interacts with this subunit. The point that always comes up is, are they sensitive to thiamine? Does thiamine make a difference? So sometimes it could be that the dose is not sufficient, and sometimes it's just they don't respond. And it's mostly not too many of them do respond to thiamine, but you have to try it, and you have to use it to see if it does make a difference. So it is the most common type of PDH deficiency, and the symptoms in females and males are equally outstanding, simply because, again, this is a very important X-linked disorder that if it's associated with any specific type of mutation that's significant to cause disease, it will lead to disease, whether it was a male or a female. The type of mutations, that this is one of the disorders that there's no good genotype phenotype correlation. Missense mutations can cause problems, as well as, for example, like insertions and deletions. There's a neonatal onset form, an infantile form, and late onset form. For the neonatal and the infantile forms, the symptoms may be nonspecific at the beginning and triggered by stress, and always, by the way, triggered by stress, fever, and illness, and high carbohydrate intake. So they'll have lethargy, poor feeding, tachypnea, seizures, which are significant, and severe hypotonia, weakness, and they tend to have some dysmorphic features that look like fetal alcohol syndrome. So they would have microcephaly with a narrow head, and then a thin upper lip and a wide nasal bridge, and sometimes the philtrum would appear long. If you do an MRI for these patients, especially those who've suffered from a complication or who are having an acute episode with decompensation, you can see gray matter degeneration with foci of necrosis and brainstem lesions. So again, all the areas that are supposed to be requiring a lot of energy and demand. So brainstem is a big one. They can have subacute necrotizing encephalopathy with Lee syndrome-like manifestations. And then one of the congenital anomalies that are there from the start, so you can see that from birth, is the agenesis of the corpus callosum. And, of course, because of all of the above, these patients will have developmental disorders and signs like mental delays, psychomotor delays, and growth retardation. I just want to say that, patients who come with spastic atypical, they call them sometimes patients who have cerebral palsy, and they seem to be atypical to the provider. They end up having PDH deficiency, the later onset forms and so forth. So it wouldn't hurt at all to evaluate those patients and think of that possibility when you're seeing them, because some have ended up being a PDH deficiency. And in that case, you may be able to provide some treatment, even if it was later in the disease course. But keeping that in mind is worthwhile to try to detect early. For the late onset PDH deficiency, this can happen it's one of those conditions that happen episodically. So a recurrent patient, whether it was an adolescent or an adult, that comes in with recurrent episodes of neurologic manifestations, ataxia, peripheral neuropathy, dystonia, that just happens and then goes away. And then if you link it to the diet, if you talk to them and you ask them, what did you eat? Did you have, what kind of meal did you eat? You usually will ask about protein, right? And if you don't ask about carbs, you're going to miss it. So these are carb sensitive patients where when they eat a chocolate bar, and I've seen one patient who just ate chocolates and he would come in with ataxia. So the problem is you have to know what induced this type of effect. And if you don't ask about carbs as if you were asking about proteins, you're going to miss it. So remember this condition, because late onset disease is one where they don't manifest when they're younger. They will manifest if they eat too much than they can cope with. But at the same time, if you don't ask about carbs, you're going to miss it. So they have ataxia, they have peripheral neuropathy, dystonia, and any one of them. So they don't have to have one or all. It can be all of them or one of them. And they can have complex, like extrapyramidal manifestations, again, the recurrent dystonia and so forth. And a blood and CSF lactate may be normal in between, but during the episode, you can see that it is abnormal at that time. So you have to catch them during the episode, not in between. In between, they may be totally normal. Their cognition may be normal, and that's what makes it hard, is you wouldn't know about this disorder unless you expect it, but you have to think about it to be able to expect it. And then the treatment is reduction of the carbohydrates and making sure that these patients are aware of their condition, and diagnosis confirming the disorder is important for them to be able to maintain their sense in terms of understanding what type of diet they can be, and the limitations of the types of food that they should have, and reduction of the carbohydrates. So we don't put them on a ketogenic diet. So if anything, it's kind of a modified ketogenic. If you just tell them lessen the amount of carbohydrates to not a severe extent as the patients that we put them on a real diet, but one that can prevent the amount of carbohydrates from being excessive to a point where they become symptomatic. If they are having recurrent manifestations and it's very severe, then in that case, they may need, as I said, a modified ketogenic diet, not a severe one, but that's something that you have to individualize based on the patient's, again, biochemical individuality. Every patient is different than the other, and you just have to understand what their lifestyle is, what their diet is like, and then suit them accordingly. And thiamine would be one of the things to give these patients. They will actually respond to thiamine better than the other patients. For E2 deficiency, the mutations in the DLAT encoding the dihydrolipomyl acetyltransferase subunit is one where, again, you have to think about the manifestation. So these patients, they're rare, but they can present later in childhood. So they don't always present earlier in life. The interesting thing is they can have generalized hypotonia, they can have psychomotor development, and that's why I'm saying you have to keep it in your mind in the differential diagnosis of patients who have, developmental delay and things like that, because it could be one of these disorders which would not be picked up unless you're testing them for it. So in this case, the lactate concentration, again, may be normal in times when they're not actively sick, but they can also show hyperammonemia and nonspecific amino acid elevations when they're sick. And that's the time where you want to check the lactate and you check the hyperammonemia and so forth. So these patients actually respond to lipoic acid as well as to thiamine and sometimes the ketogenic diet if needed, again, based on how severe it is. The interesting thing about the MRI or the imaging is they have lesions in the globus pallidus that looks like the pantothenate kinase associated neurodegeneration. So that PCAN, one of the iron deposition disorders that we kind of talk about that specific sign, the eye of the tiger. So they can have a hypointensity of the globus pallidus that looks similar to the PCAN patient. So something to keep in mind if you have a patient that shows that finding on the MRI, but doesn't have PCAN. The other thing is E3 deficiency. That's shared with the two other enzymes, alpha-ketoglutarate dehydrogenase, as well as the branch chain ketoacid dehydrogenase, which is, again, the enzyme that's associated with maple syrup urine disease. The clinical features are typically Lee syndrome when they have a severe disease, and then milder variants also have been described. And for the severe form, they usually don't respond well to treatment. So any of these disorders, you can confirm the diagnosis with mutation testing. And if you don't find a mutation, but you are very suspicious of the disease, go to del-dupes. Okay, that's very important, especially for the X-linked disorder and so forth, because if you can't find something by sequencing, it may be a deletion that is missing there. And then it's important to do, if again, you're suspicious or the mutation is non-specific and you want to confirm, sometimes you have to be a bit invasive and do enzyme testing in fibroblasts. And, there are labs, Cleveland Clinic, I believe, does the pathway for the fibroblasts for the pyruvate pathway metabolism. And then lactate and pyruvate, that can be elevated in the blood and the cerebrospinal fluid. The lactate to pyruvate ratio is only diagnostically useful, and that's a very important point, if the lactate level is higher than 5. So if the lactate level is not high and you see a difference, it might not mean anything. It's so important to keep that in mind. It's always hard to do the pyruvate right, but if you can do it at the right time in the right lab by checking lactate and pyruvate at the same time, and they run it well, you can only interpret that ratio if you see that the lactate is higher than 5. Okay, and in these conditions, because you've got pyruvate metabolism disorder, both the lactate and the pyruvate are going to be high, so the ratio is low or normal. So keeping that in mind, so it's different than mitochondrial conditions or respiratory chain conditions where you have a high lactate and a relatively lower pyruvate, and in that case, the lactate to pyruvate ratio is high. Okay, and then you can have also elevated serum alanine, of course, when you have, here, just going through that pathway again, sorry about that. So if you have lactate and pyruvate here, the additional thing that lactate can change into is alanine. And so any of those can be abnormal in those patients. So if you check plasma amino acids and you see that alanine is elevated in the presence of lactic acid elevations, it's one of the signs of the disorder, but it's not diagnostic on its own. So for the lab diagnosis, in terms of the analytes that are there for the different types, so for E2 deficiency, you can have, again, a high non-specific serum amino acids with hyperammonemia. So always, if you see the ammonia elevated, some elevations in the amino acids and lactate markedly elevated in a patient who has neurological manifestations, plus, other of the non-specific and MRI or brain imaging that's significant, you can think of E2 deficiency. E3 will be associated with high branch chain amino acids as well as alpha-ketoglutarate in the serum and urine because of where it is and its conjunction with the alpha-ketoglutarate and the branch chain ketoacid dehydrogenase enzymes. They will have lactic acidosis, and for the E3, you can see those branch chain elevated and MSUD-like metabolites in the urine organic acids. So treatment of these conditions in general is thiamine as well as a ketogenic diet. For PDH deficiency, the idea about the ketogenic diet is one where neurology will give a strict ketogenic diet if, for example, the patient has seizures. So the point is, what do you want to do? And where is the patient and how is the patient doing? So if the disease is severe, you want to, and you're starting early, you do want to give a significant ketogenic diet. What is a significant ketogenic diet? So a 3-to-1 ratio. So where you have, for example, beta, if you're looking at beta hydroxybutyrate levels, you want to have at least a level of 3 in the blood to make sure that you've reached a ketotic level that is sufficient enough to be, helpful for the patient. If you go up to 4, that's okay. But if you go up to 6, that's too much. That's ketoacidosis, and it can be associated definitely with, side effects. And you do want to keep an eye on the child himself. With a ketogenic diet, the children sometimes don't grow that well. So, personally, we've looked at it. I've had a patient and we've looked at it. And when he was at 3 versus at 2, it was the same thing. So if you're still above like 2.5 or 3 to 1, that is perfectly fine. If the beta hydroxybutyrate is in that range, that can be well. It kind of prevents the seizures and helps with the lactic acidosis. So it suppresses the lactic acidosis. And I would say it's so important to make sure that they're on carnitine, because when they have a lot of ketones, carnitine gets conjugated and then carnitine becomes low. So it's important to give carnitine, and it's important to give lipoic acid if the lactic acid is not coming down. So lipoic acid, again, is one of the important parts of bringing down the lactic acid, and it's helpful for the patients with the type 2, E2, or specifically the E2 one it's the cofactor for it. So anyway, the thiamine responsive cases are rare, but they are in the children who are diagnosed later than 1 year old. So that later onset disease form, and they can go up to a dose as high as 400 milligrams per day of thiamine. So you can go up on the dose and see how they do, but just keep it within a range. So if you note any side effects or anything, there's not too many that we know of with thiamine, but I would be careful with B6 because that's associated with peripheral neuropathy. Now, that's totally away from this situation, but just keep in mind that when we increase the vitamin doses, we have to be cautious about the ones that do cause some side effects when you go up too high. For ketogenic diets with restricted carbohydrate intake, you have to, again, make sure that you're giving them protein, you're giving them lipids or MCT. That can happen from MCT, and they get a small amount of carbs, but the idea is the dietitian has to be there to a point where she's making sure that the patient's getting, in the ketotic range, at least above, not undetectable levels of ketones, because you're not doing anything if you're not showing any ketones. So as I was mentioning, if you go up to a level of 2.5, up to 3, that's perfect. Just don't go too much above, like don't go to 6, don't go to 5, that's too much. And the main thing is, if the patient has seizures, definitely you will need the higher doses. If the patient has a milder phenotype, but has significant disease, hypotonia, all of that, you should have some ketones in the blood. It should not be undetectable. Dichloroacetate is, has been there in research clinical trials for a long time. What it does is it inhibits the phosphorylation of PDC, and it allows the resolution of the lactic acid in some patients. The point is it's not available all the time, and there's still clinical trials about it, and it has been associated with peripheral neuropathy in some patients, and co-administration of it with thiamine has reduced the peripheral neuropathy, at least in animal models. The point is the peripheral neuropathy part is more associated with MELAS, for example, so other conditions. So you have to be careful about when you're using dichloroacetate, what are the conditions that you're using it with in a lactic acidosis situation, and making sure that you are updating yourself with all the results of the clinical trials as they become available. And then the other thing is it's investigational, so keep that in mind. Oral citrate can be used, and that's mainly to treat the acidosis when these patients have it. And if they're severely acidotic because they've been overly ketotic, you can modify that by adding a little bit of carbs, and the ketones are going to come down. So it's a balance, and you have to it's actually a part of an art to be able to handle that in a way where you bring back the balance to where you want. So if you overshoot, bring it down. If you're undershooting, bring it up. For pyruvate carboxylates, that's another one of the pyruvate metabolism disorders, the first step in gluconeogenesis, and it's one of the important enzymes because it catalyzes pyruvate into oxaloacetate. There's other two gluconeogenic enzymes, fructose 1,6 bisphosphatase and glucose 6 phosphatase. So again, fructose 1,6 bisphosphatase, I'll talk about it today. glucose 6-phosphatase is our GSD type 1. So these are the important gluconeogenesis enzymes that are there. There's another one, pyruvate, which is PEPCK, and I'll talk about it a little bit today. Again, rare deficiency disorders. So the essential role for pyruvate carboxylase is repleting oxaloacetate, which is important for the TCA cycle. So definitely it is an enzyme associated with anaplerosis to the tricarboxylic acid cycle, besides the gluconeogenesis potential and role. It uses biotin as a cofactor because it's a carboxylase, and then it's tissue specific. So liver, pancreas, brain, and adipocytes, have an expression of it and a range of it that's different than, so special for each organ, specific for each organ. And then it controls the fuel partitioning towards the gluconeogenesis, lipogenesis, and insulin secretion. So very important there. The clinical spectrum is very broad. It can be mild to severe. So patients can have failure to thrive, developmental delay, recurrent seizures, and metabolic acidosis because of the lactic acid that accumulates in these patients. Again, pyruvate metabolism disorder. Brain MRI can show symmetric cystic lesions, gliosis in the brain, and basal ganglia. Again, one of these disorders that highly, touches the brain or bites the brain, if I could say that, because there's lots of neurological manifestations associated with it. If you do an MRS, whether it was in PDH or in pyruvate carboxylase, you can see high lactate levels in the brain, and those will be in the areas of the brain where there's more energy and demand. So even when you see, for example, a potential for the lactate to be high, if there's a stroke-like episode, in this case, the distribution of the, if there was stroke-like episode, would be the areas of energy demand, not vascular supply. So that differentiates it from vascular strokes and so forth. And then the pathophysiology mainly is that you have a glutamine to glutamate cycle in astrocytes that requires a continuous supply of oxaloacetate, provided that by that reaction that is catalyzed by the PC enzyme activity. That's for the brain in general. So there are 3 types that we recognize. Type A, which is the infantile or North American form, and those that's a very severe form where most die in infancy or early childhood. And then type B, which is known as the French form or the severe neonatal form, and that's the one that's associated with hepatomegaly. They can have hyperammonemia, pyramidal tract signs, and abnormal movements, and early death. And they have a clinical biochemical phenotype that I will discuss. And then type C, which is the intermittent, or sometimes called the benign form, which have normal to mild delay in developmental and episodic metabolic acidosis during illness. So that last type, if you think about it, we have triheptanoid now, which is one of the anaplerotic agents. When you give the patients with, the type C, the drug, if they have manifestations, then they do well with it because these patients have less of a severe disorder. So for the biochemical findings, based on pyruvate carboxylase deficiency type A, they tend to have mild to moderate lactic acidosis and normal lactate to pyruvate ratio for the same reason, is both lactate and pyruvate are high, so you don't have a difference between the two. That is not true for type B. You have an increased lactate to pyruvate ratio because, again, there's a type of like a reduction defect at the level of the liver, and these patients have increased acetoacetate to 3-hydroxybutyrate ratio, so they can also have ketosis. So type B looks like respiratory chain defects, mitochondrial respiratory chain defects. They can have plasma amino acids that shows a specific elevation in citrulline. So again, this is one of the conditions that's associated with elevated citrulline. They also have proline, lysine, ammonia, low glutamine, and the ammonia is high. And the ammonia is high because aspartate gets depleted in these patients. So keeping that in mind. So the urea cycle is involved secondary to the defect that's there because they have less oxaloacetate and then less aspartate, and that would lead to a decrease in the substrates for the urea cycle. Type C, episodic metabolic acidosis, they can have that from time to time. Their plasma amino acids are normal in terms of the citrulline, but they have elevated lysine and proline. And then the LP or the lactate to pyruvate ratio is usually normal in pyruvate carboxylase deficiency type A and type C. For the biochemical findings in pyruvate carboxylase, again, to reiterate the importance of the ones that have the biochemical abnormalities shown, you have high alanine, citrulline, and lysine in the French type with low aspartic acid and glutamine. These patients have hyperalaninemia as a result of the pyruvate shunting. They have the high citrulline and the high lysine because there's a block in the urea cycle secondary to low aspartic acid. And that's important to remember. And then the low aspartic acid and the glutamine is a result of deficiency in the oxaloacetate precursor. And I'm just saying that for biochemical fellows, it's important to remember these things for the boards. I'm not giving anything away, but these are the things that you have to know as a biochemical geneticist. What is the cause of the abnormalities or the secondary changes that happen in these disorders? And then they have ketonemia with 3-hydroxybutyrate acetoacetate levels increase in the blood. For the type B, again, why are you seeing all these abnormalities? Well, there's a reflection of a reduction abnormality. So you have low NADH to NAD ratio inside the mitochondria. There's lack of the oxaloacetate. You can have hypoglycemia, but hypoglycemia is not a consistent finding, even though PC is the first rate limiting step, and that's because other, pathways are stepping up in that situation. There's other things that are happening that are preventing that hypoglycemia, but you could have hypoglycemia in severe cases if they're vomiting, if they're fasting, if they're anything like that. So it's not routinely seen if the patient is, not throwing up and so forth. But if they're not able to tolerate feeds, you will see it. Hyperammonemia, I spoke about it. And then the CSF changes are, some of the same things that you would see in the blood. The treatment usually is ineffective, but we could say that some patients do well with the, again, milder forms if you give them citrate, aspartate, or triheptanoid. So basically anaplerotic therapy. So the idea is oxaloacetate is not being formed, and that's important for anaplerosis for Krebs cycle. So what you want to do is fill Krebs cycle. So how do you do that? You can do it either through giving substrates as citrate, aspartic acid, or triheptanoid. And what does triheptanoid do? Since it's an odd chain fatty acid, and it's not it's not a protein like the others. So basically it breaks down into 2-acetyl that goes into the mitochondria immediately. And then at the same time, it's C7. So it breaks down into 3,3, which is the propionyl, and that goes through succinate pathway. And then it breaks down also into C5 ketone bodies, which actually can cross the blood-brain barrier and therefore provide a substrate of energy to the brain. So that's how it works. Some patients have received liver transplantation. And what all of these do is, in one way or the other, they can reverse the biochemical abnormalities, but they can't change the neurological manifestations that are there. So they can help with the stability of the metabolic part in terms of the acidosis and so forth, but not with the neurological signs. And then there's phosphoenolpyruvate carboxynase deficiency, another gluconeogenesis defect, very rare, but the enzyme itself catalyzes the conversion of the oxaloacetate from pyruvate into phosphoenolpyruvate, which is a gluconeogenic intermediate. So the deficiency with this condition, and why am I bringing it up? Because it's coming up on whole exome sequencing now. So in patients where they have hypoglycemia, lactic acidosis, and you would think of GSD and all of that, and you do whole exome, it comes up. And you need to know a little bit about that. So this deficiency is associated with hypoglycemia and lactate, pyruvate, and alanine elevations. In humans, there's 2 types of deficiencies. There's a cytosolic one, which is encoded by PCK1 or PEPCK1. And then there's one that's in the mitochondria, and they're 2 different genes, and they participate both independently in gluconeogenesis. So for the cytosolic as well as the mitochondrial, they both have hypoglycemia. The cytosolic is associated with hyperinsulinism. That doesn't happen with the mitochondrial form. And then the cytosolic is associated with the gluconeogenesis part coming from the amino acid and pyruvate. And you can see they're 2 different chromosomes, 2 different genes. But then the synthesis of the mitochondria, the glucose comes from using lactate as a substrate. So you'll see more lactic acidosis when you have a deficiency in the mitochondrial form. So the lactic acidosis may be seen in the mitochondrial more than the cytosolic form. They can have muscle hypotonia as a manifestation. The features can happen in the neonatal period of time or after birth, and hypoglycemia can occur in acute episodes. They can have severe lactic acidosis specifically or especially the group of the mitochondrial disorder patients. And then because it's rare, we don't have too many, but I can tell you that I've seen it twice. Progressive neurological deterioration, severe liver failure, renal tubular acidosis, and Fanconi's syndrome can happen again because these are the organs that are associated with gluconeogenesis, both the liver and the kidney. They can have failure to thrive and muscle weakness, microcephaly, cardiomyopathy, and so forth. So just keep that in mind. And then I'm going to go to fructose metabolism. I'm hoping I'm doing good with time. So fructose metabolism, the three big ones are hereditary fructose intolerance, and then fructose 1,6 bisphosphatase deficiency, and then the benign one, which is fructosuria due to fructokinase deficiency. I'm not going to go to that one, but I do want to let you know that I am going to talk about hereditary fructose intolerance, which is right here, caused by that aldolase B enzyme. And then the fructose 1,6 bisphosphatase deficiency, 1,6 diphosphatase or bisphosphatase, which is right here. And just again to let you know where we are is both sucrose and sorbitol will break down into fructose. So when we talk about fructose metabolism and we tell patients, not to take anything that contains fructose, we include sucrose and sorbitol because sorbitol is the alcohol form of the fructose, and it can change into fructose as well as sucrose. It breaks down into fructose and glucose. So hereditary fructose metabolism, one of the interesting disorders, and nice to diagnose and pick up because you can change the outcome of these children very well and very easy. So patients will develop symptoms when they're exposed to fructose, sucrose, or sorbitol. And what are those symptoms? Vomiting, diarrhea, abdominal pain, hypoglycemia. And then if you check their liver functions, and if they come to you jaundice, you'll see that they have significant liver failure. They can have renal tubular acidosis. So this is one of the conditions, inborn error of metabolism associated with renal tubular acidosis, and proximal renal disease is aminoaciduria is HFI, always to remember that one. And then if you still have the ability to check for reducing substance in urine, it is going to come up as a reducing substance other than glucose. So you would have an idea that if it's other than glucose, it may be fructose. So it's one of the things that was, helpful when available, but currently it's not available that much to do the sticks that show that. Usually it occurs after weaning. And I'm going to say that because it occurs when you start introducing things that have sugars. But lots of the formulas, the baby formulas, currently have fructose. So you can see it earlier in a baby who is receiving not breast milk, but a formula that contains fructose. So always go back and look at the formulas. And if you see a baby in liver failure, look at the formula, because if they're on fructose, it can be as early, neonate and infantile age without weaning. So it's important to always look at the formula. And I've seen it twice in a situation like that. So it's there. The deficiency of the enzyme is aldolase B, which is supposed to split the fructose 1 phosphate into dihydroxyacetone phosphate, glyceride in the liver and small intestine. And then what happens, and the proximal renal tubular, again, the reason why this renal tubular acidosis is there. So what happens is you've got a mutation, fructose ingestion occurs, and then you have accumulation of the F1P. That is actually toxic. And once it's toxic, it traps the phosphorus and it leads to a block of the glycogenolysis and the gluconeogenesis. And that's why it leads to hypoglycemia, the lactic acidosis through the glycolysis defect. And then the other thing is you have depletion of ATP. And because of that, you're going to have increased production of uric acid. So you're going to see hyperuricemia. You may see problems with magnesium, and then you can see the liver failure and the renal failure. So just to let you know how fructose can be bad. So IV fructose in toxic healthy adults, if you give them high amounts, they can get liver symptoms, or they can vomit. But I want to say, do not use that to challenge it. So even in healthy adults, it's not good. And then in carriers, if they're exposed to fructose about more than 50 grams, they can develop hyperuricemia and gouty attacks. So you don't even want to try it in carriers. The idea is we don't do any fructose challenge. We don't do that. It used to be a practice in the past for diagnosis. We don't do that anymore. The lab findings in those patients, lactic acidosis, hyperuricemia, hypoglycemia, and then you see the elevated transaminases, the INR, because of the liver dysfunction, and you can have, a cholestasis abnormality associated with it too, GGT, alkaline phosphatase abnormal. You can see, depending on the stage and the phase that you're looking at the liver, hepatomegaly, echogenic liver, steatosis, fibrosis. Once the steatosis is there, if you pick them up and you treat them early, that can improve. But if the fibrosis sets in, you will see it. It just does not become progressive when you start treating these patients. So the idea is pick it up early, diagnose them, get them out of the liver failure, and then continue to follow them with the hepatologist because they will need to follow them over time. The diagnosis is one to make out of suspicion. For a child who eats a piece of cake or candy and then gets into trouble, that's easy to make the diagnosis. The problem is the younger ones that will come as an infant or as a neonate with liver failure, and you have to think about it in that setting and look at the formula that they were on. If there's no mutation, and you still have a strong clinical and nutritional history deficient, you can see that altolase activity in a liver sample might help confirm the diagnosis, although that would be invasive, but it's something that you can do. And then the treatment is basically avoiding fructose, sucrose, and sorbitol in the diet, and the other sources, for example, medications and so forth, because of course, for children, they add it as something to make it taste better. And then the prognosis is usually excellent for untreated cases. For treated cases. Untreated cases will lead to liver failure and renal disease. And it's always important, and these are kind of pearls to remember. So patients with HFI, because they don't eat fruit, since fruit contains fructose, they will have problems with iron deficiency anemia because they can have vitamin C deficiency. So you want to prevent that. You want to make sure that they're on vitamin C, and you want to make sure if they have iron deficiency anemia that you are either checking the level of vitamin C and giving it, or empirically just give vitamin C with iron, because vitamin C improves the absorption of iron. The other thing is, because again, these patients are at risk of iron deficiency, you have to check them and treat them. Immunizations are usually safe. There has been more than one, like documentation that the drugs and the immunizations that are made with tracking levels of fructose to make sure that there's no toxicity to those patients. But it doesn't harm to look at the drug and to look at how high the fructose amount is. Usually it's not enough to cause problems, but it's important to give it to the child when they're normal and they're healthy, not when they're sick. So not at a time when they're not feeling well or anything like that, because you can have elevations in the liver enzymes due to that, and not due to the fact that it's the immunization. You don't want to scare the family. You want to make sure that they understand that it's not due to the vaccine. The other thing is these patients tend to have isoelectric focusing abnormalities. So sometimes they're going to give you a picture of an abnormal, it's not a CDG in particular, but it gives an IEF, carbohydrate deficient transferrin abnormality that will be picked up if you are sending that, because CDGs also have liver disease, so you may pick up something like that. And then these are the children that have lack of cavities because they avoid candy and fruit and all that makes them sick. So to that aversion to the fructose part keeps them without cavities. Then we have fructose 1,6-bisphosphatase deficiency. That's the key rate limiting gluconeogenesis enzyme. It's a deficiency that prevents formation of glucose from lactate, glycerol, and gluconeogenic amino acids as alanine. So in that case, what you have a problem with a tolerance to fructose. If it's so their tolerance is better than HFI. So if you give them acutely, small amounts, there's not going to happen. Chronic amounts, small, over time, not going to happen. But if it's too much over time, chronically, they might not have any vomiting after ingestion, but they can develop problems with, for example, hypoglycemia, as well as liver dysfunction. So the triggers mainly are when they're fasting or they're catabolic, if they have diarrhea, if they have fructose ingestion approximately 1 gram per kilogram. So larger doses over periods of time. Clinically, they can have the hypoglycemia, the lactic acidosis, hyperuricemia, ketosis, and liver failure. So, they look so much like GSD1. I just want to say that. So they will have lactic acidosis, hyperuricemia, hepatomegaly, but that liver failure gives them away. GSD1 is less likely or doesn't hardly causes liver failure, but fructose 1,6-bisphosphatase, it will cause liver failure. So that's one thing to keep in mind. And then these patients have ketosis. GSD1 are more hypoketotic. They can have ketones, but not as much. And then metabolic decompensations, kind of decrease with age as they become more adults and tolerant of the catabolic stress, and they know what to do. Pregnancy is a risk factor for metabolic decompensation due to its increased glucose requirements. So you kind of have to keep an eye on them. And glucose is fine. The problem is just avoid fructose. So the clinical signs are similar to GSD1. Neonatal hypoglycemia is a common presentation in this condition, and it can be associated with coma or irritability and a moderate hepatomegaly, and you have to put it in the differential diagnosis. Important sign. So again, they look like GSD1. So triglycerides may be elevated in GSD1, but here they can have pseudo hypertriglyceridemia, and the triglycerides here may be a sign that glycerol is elevated. And for those who are in the biochemical genetics lab, as well as the clinical biochemical geneticist, medical biochemical geneticist, this is important to remember, because in crisis, you can see on the urine organic acids elevated glycerol. And that triglyceride, if it's very high, it can be representing the glycerol. So you have to look for it in the urine organic acid, because that's, again, a clue to the diagnosis of these patients. So by the way, elevation of glycerol can happen in glycerol kinase deficiency as well, and in patients who have any like diaper rash and they're putting on them Vaseline or anything that contains glycerin. So you have to make sure that glycerol in the urine organic acid, when you repeat it, is there and the amounts are significant, and that the patient has not had anything that had glycerol in the diaper area. Treatment is prevention. You prevent fasting. You treat using IV glucose during the acute episodes of the illness. And then you give them they can have small amounts of fructose, less than 2 grams per kilogram per day. They can tolerate that, but a single ingestion of a high dose, more than 1 gram per kilogram, is harmful, especially in the younger children. And that's important to remember. So they can tolerate if you're giving it throughout time in small amounts, but they can't tolerate an acute high dose. But they're not as bad as the others. The others are going to show you immediately. These might be sick a few days later if they continue to have that acute exposure. Practice pearls, hypoglycemia in the neonatal period, you have to remember, especially in the first 4 days resulting from deficient glycogen stores, is think of fructose 1,6-bisphosphatase as well as GSD1. As well as the endocrine causes, of course. Those are things that have to be ruled out. Pregnancy, they will need home glucose monitoring, and sometimes they might need cornstarch at night during pregnancy. And glucose is no harm to them, so the only problem they have will be with fructose. And then if you see increased glycerol 3-phosphate in the urine organic acid, glycerol is elevated, in these patients, but you have to see it in the urine organic acid that is persistent. And the other thing is, because there's a differential diagnosis, you have to think about the other conditions as well. Glycerol kinase, by the way, is X-linked, so you have to think about that condition, as well as it sometimes can be associated with the microdeletion syndrome. So keep that in mind when you're thinking about glycerol in the urine and glycerol kinase as a reason for it. So HFI, the children have a strong aversion to sweets and no teeth cavities. They have failure to thrive with chronic fructose ingestion, and they have renal tubular acidosis. The fructose 1,6-bisphosphatase deficiency, children do not have GI symptoms or failure to thrive related to chronic fructose ingestion, but they can develop with an acute ingestion of a large amount or if they've been receiving high amounts chronically. And then detection of glycerol or glycerol 3-phosphate is mainly in the fructose 1,6-bisphosphatase and not in the HFI. Then I'm going to go to the galactose pathway disorders. So chronic galactosemia, or I'm sorry, classic galactosemia is one that we encounter a lot because we get it on the newborn screen when it's picked up. It's due to galactose 1,6-bisphosphate, galactose 1-phosphate uridyl transferase deficiency or GALT deficiency. And then we have another disorder called GALE, or uridine diphosphate galactose 4 epimerase deficiency. That one is, more rare, but I'm going to talk about it since we've been seeing it on newborn screening, or at least one of its variants. And then profound, it can be associated with a profound deficiency that resembles classical galactosemia, and that's very rare. But then that partial deficiency, which is usually benign, is more frequent. And then we have the galactokinase deficiency, which is the one that's associated with the cataracts. That's extremely rare and more insidious, and it results in the formation of nuclear cataracts without provoking symptoms of intolerance, and it doesn't lead to liver disease. I just want to say one of the other galactose abnormalities is Fanconi-Bickel, because it's associated again with galactose abnormality. If you want to think about something else that causes galactose, remember citrin associated disorders. So anyway, when you have exogenous milk or galactose or lactose, and you have a pathway defect here, if you are thinking about what happens first, depending on where that enzyme is. So if we're talking about GALT, the one associated with the classic galactosemia, it's right here. So it's associated with Gal1P changing into glucose 1-phosphate. So you're going to have an elevation of galactose 1-phosphate. That galactose 1-phosphate is actually incriminated, or the offending agent for the liver. It's associated, it's toxic, and it's associated with the liver disease. Going back up, you also have elevation of galactose. So these are the substrates that are involved or accumulate with the classic Gal1P, and then galactose. And what happens is when you have too much galactose, that actually through aldose reductase, so that's an alternate pathway that happens when you have too much galactose, it's going to change into galactitol, which is the alcohol form of the galactose. And what happens is galactitol actually is what goes into the eye and changes the membrane consistency and leads to the lens cataracts. So that is associated with the cataracts, the galactitol. Gal1P is associated with the liver disease. And those are the two that are elevated with classic GALT deficiency. If you look at GALE and where GALE is, well, GALE leads to that UDP and the biosynthesis. So it's actually in that same pathway realm. It's associated with the same effects. So you also can have Gal1P elevation. You also can have galactose. And that's why I'm saying the severe form is associated with a picture that looks like the classic disease. But we have instead a form that the disease is only deficient in the red blood cells, and that's what we're seeing more. So they have a biochemical level that shows Gal1P elevated and so forth, but it may be simply in the RBC and not in the real disease, not in the liver. So newborn screening has come up with some of these patients that we are seeing at times, and you have to do the additional tests to be able to reflect that, to see what's going on. We have galactokinase deficiency, which is the disorder that's associated with the cataracts. And here you see accumulation of galactose, accumulation of galactitol, and that's why they have cataract, but they do not have liver disease because it is before the formation of Gal1P, so there's no problem there. For classic galactosemia, whenever you consider a galactose disorder, stop milk feeding first. There's no problem, no harm there. Just replace with soy or whatever non-galactose containing formula. If you have a suspicion, stop it. Okay, classic galactosemia is life-threatening. It's associated with complications, including feeding problems, failure to thrive, of course, liver failure, E. coli sepsis, and untreated infants. And then when you treat these patients with restriction as soon as possible, especially during the first 10 days of life, of course, the sooner the better, you are able to resolve these signs and prevent these complications from happening. Now, even though you treat these patients and you prevent, you restrict the galactose, they still continue to have problems as they grow and become adolescents and adults. We do see adults, even when they're under good control, they can have problems with speech, this R3 and so forth. And then depending on the type of the mutation, especially with the classic mutation, this glutamine to arginine, they tend to have premature ovarian failure and infertility in those patients. And you know, the patients who have that premature ovarian failure, the signs of it is those patients who have, or you know, you can predict them if you have the mutation, or if the erythrocyte Gal1P is greater than 3.5 during therapy, or if they have you know, 13 galactose oxidation, which we don't do routinely, so I'm not going to go through that part. So for the newborn screening, if it comes positive, you want to send out for GALT activity in the lab. You want to make sure that you send the biochemical. So the patient with a positive newborn first screen for galactosemia, you know, they repeat the lab, they see that it's persistent, they see that it's abnormal, depending on which state and what they do, whether they're doing galactose or they're doing galactose plus GALT plus 1P, whatever they're doing, you're going to send GALT activity to the biochemical lab, and you are going to send Gal1P. And remember to do that before giving packed RBCs, because they're in the red blood cells. So basically, if you are going to give them a blood transfusion, you will get a false normal or negative result simply because you're picking up what's in the donor's red blood cells. The other thing is if you have urine, you can get galactitol in urine, and you can, of course, do the mutations testing. So I want to just say the galactitol in urine is very hard, but you don't have to do it at the beginning if you can't. But what you want to do is GALT activity, Gal1P, and mutation testing. Those are very important. The other one is, if you can do it, that's good, but if you can't, it's okay. Standard of care in any newborn who is screened positive is immediate dietary restriction of galactose in the diet while the diagnostic testing is underway. And I told you galactitol, it's okay if you don't do it, but if the patient had RBCs and you're worried about the Gal1P, you can do galactitol in urine for that situation. And then if the erythrocyte galactose 1-phosphate concentration is more than 10 and the GALT activity is low, you know, you worry about the classic galactosemia, or what we call the clinical variant galactosemia. I'm going to talk about each. And then what you want to do is you want to restrict galactose, and then through all the milk products, as well as anything that they're taking, that medications or anything that may have galactose in it. For the types and the genotype phenotype correlation, so you can always go back to gene reviews and look at the table there. It's very helpful, and it's a very good, very well written, by the way. So classic galactosemia are the ones that are associated with the real disease, meaning these patients are going to go into liver failure, and you have to put them on the diet, and you have to make sure that everything is going well with these patients, making sure that you've done all the labs. And you put them on the diet early, as soon as possible. And to be honest with you, these are the ones that are problematic, the classic galactosemia, as well as this clinical variant galactosemia, because even with this mutation, so this is a mutation that is common in African Americans, and you see it, but when it is a pathogenic disease-causing mutation, if it's associated with one of the classic galactosemia, other ones, so it's heterozygous, it's going to be a significant disease. And even if it's homozygous for that same mutation, you're going to see, again, GALT activity that is reduced, and a risk. Maybe less severe than the classic galactosemia, but you have to know that this is a real disease, and these patients should be on, again, diet, and should be followed over time. The point comes to the biochemical variants, which we see, you know, Duarte and you know, if they're carrier for one with a pathogenic mutation versus Duarte, and all of that. So lots of, you know, papers have spoken about what to do in those cases. If it's Duarte, do they need treatment or not? And, you know, some providers will give treatment at the beginning for a year, and then, you know, take them off and see how they do. When you have a pathogenic mutation, you tend to do that generally to just see how the patients fare. And then when they're older, you might decide, you know, otherwise. But anyway, it's very different based on for the biochemical variant, based on the type of the mutation that's there. So for galactokinase deficiency, secondary to pathogenic mutations in the galactokinase gene, you have to again prevent so you try to limit the galactose, but I think there's a few less restrictions in the diet now, and if anyone wants to correct me, please feel free about that. But anyway, these patients, you follow them over time. You need to make sure that you're checking the galactitol level in those patients to make sure that it's level. But again, restriction of galactose is the primary thing that you do. For the epimerase deficiency, depending on the type that you have, if it was the biochemical variant or the one that's in the RBC, we usually don't treat. But if it was the one that's associated with the liver disease, the GAL1P is high, galactose high, normal, the GAL1P high and the galactose and normal GAL, that's the one that is relatively benign, let me put it that way. The one that has a severe systemic manifestations with the risk of the liver disease, that's the bad one. For that one that's relatively benign, we see that it's relatively in the RBC. There are some mutations right now that they're starting to do genotype, phenotype manifestations. But if you do the enzyme activity in the red blood cell, you're going to see that the enzyme activity in the red blood cell may be deficient in those patients. So it can be simply, it's because of a red blood cell abnormality and not a general abnormality. Okay, galactose 1-phosphate uridyl the classic galactosemia type. The severe gout is one where you have to treat, no question there. For patients who have one mutation and not the other, so if they're carriers and so forth, you don't worry about those, you don't have to treat the carriers. The idea will be what is the clinical variant galactosemia? So those are the patients who have a residual enzyme activity in the erythrocytes and or the liver, but at the same time, they're at risk of disease because the gout activity is still lower than usual. For those patients, again, based on the mutations that you're dealing with and based on the clinical situation of the child, you might want to treat. I mean, usually we treat them, so we treat them. For the biochemical variants, the Duarte type, this is the one where we have variability in how the practice is done. So for the Duarte variant, the D2, if it's in cis configuration, so you've got a pathogenic missense mutation, which is, for example, the P asparagine to aspartate, and the GTCA deletion in the promoter region. So if you've got that combination, that impairs a positive regulatory domain, and that one is considered one of the Duarte variant type 2, and it's associated with a reduction in the activity level, but not sufficient enough to cause a severe reduction and disease. So it's reduced by they have at least 25% activity or so forth. For the Los Angeles variant, they actually have increased activity, and in this case they have the missense mutation, but it does not have that GTCA promoter deletion, and it's in cis configuration with the missense variant, the P leucine 218 leucine. This variant does not cause galactosemia and is associated with the increased gout activity. So in that case, they have about a 75% of the gout activity. So those patients, you don't treat them at all. So Duarte, depending on if it's Duarte, you don't treat. If it's Duarte with a classic mutation, you may want to for some time, and some don't. I mean, it depends really on the comfort level and the picture of the patient and the classic mutation versus one of the other mutations. And then in the biochemical variants, so that erythrocyte galactose 1-phosphate, usually more than 1, but maybe as high as 35. When that individual is on a lactose-free diet, the level is usually less than 1 milligram. But what you want to do or look at is the residual erythrocyte gout activity. It's usually more than 15% and average 25% of control values. So you look at that value and you see what you have, and then you determine what's going on with the patients. I mean, I've had 2 of them, and we ended up taking them off the galactose restriction, and they've done well. For pentose phosphate pathway, This is the last group of disorders. Do I have time for it? Do I have time for it? Can I?
Yeah, go ahead.
Okay. Okay. So this is a metabolic condition that parallels both the glycolysis generating the NADPH pentoses, the 5-carbon sugars, as well as the ribose 5-phosphate. It does involve glucose oxidation, and it's an anabolic rather than catabolic role in this situation. So it's an interesting disorder because it's associated here. Oh, well, I think I have it close by. Okay. Because it's associated with the 3 pathways at the same time. And it's important because it generates the precursors for the nucleotide synthesis, which is important for the red blood cells. It has an oxidative role that's irreversible. It generates NADPH, which is important, again, used for fatty acid and cholesterol synthesis and for maintaining reduced glutathione inside the red blood cell. So it's important for, again, the reductive status in the red blood cell. And then it has a non-oxidative role, which is reversible. It generates intermediates like ribose 5-phosphate and glyceraldehyde, and those are important for nucleotide synthesis and glycolysis. So the pathway itself is in proximity to both the glycolysis pathway as well as the glucuronic acid pathway. And again, the main role is, as I said, it maintains the integrity of generating precursors for nucleotide synthesis, which are important for the red blood cells. And then at the same time, it works with the glycolysis pathways and restoring intermediates for that, and the oxidative potential. So what happens is you can have glucose oxidation that does not directly consume or produce ATP through the use of this. So it's an alternative route for glucose oxidation that does not consume or produce ATP. But then at the same time, it produces NADPH and the fructose 6-phosphatase and glutathione, which helps with the prevention of the oxidative damage and generation of the ribose 5-phosphate. So you can see here, so we talked about the glucose changing to glucose 6-phosphate and so forth. So this is going through the ribulose and the pentose. The pentose is the 5 carbon, so ribulose, xylulose, ribose, 5-phosphate, and you have to kind of think about them in terms of these are pathways that are helping with generation of precursors that are going to continue to provide nucleotides for the biosynthesis of again important nucleotides in the pathways for the other pathways to continue. So one of the conditions that's important or comes up a lot is the transaldolase deficiency. And it is one of those conditions that's associated with the pentose phosphate pathway. It's associated with liver failure, glutathione defect. They have problems with depletion of NADPH and glutathione, and they have less production of nitric oxide, and that leads to decreased mitochondrial transmembrane potential and mitochondrial mass. So they have secondary effects due to, again, the lack of generation of these important energy demanding substrates. So it's a rare autosomal recessive disorder, and it was described in 2001. And the presentation is one that occurs prenatally with intrauterine growth restriction. But then in the neonatal period, you can see dysmorphic features. They can have cardiovascular defects and hepatosplenomegaly. And then later in life, they, some patients can have a milder phenotype when they present. And their ethnic background is mainly in populations where there's consanguinity, so Middle Eastern, but there's also in some Asian, West Asian, Turkey, European, and West African. And as I said, 81% of the parents were consanguineous. For the manifestations of the phenotype, so they can have cutis laxa with wrinkled skin, and especially if you look at the knuckles, and then they can have cardiac abnormalities as congenital heart disease, septal defects, bicuspid aortic valve and coarctation. Then they can have hepatic abnormalities, hepatomegaly, splenomegaly, 2 patients did receive liver transplant for progressive liver failure, and then hematological features, anemia and thrombocytopenia. So when you have cutis laxa, cardiac abnormalities, including like congenital heart abnormalities, hepatic abnormalities, and hematological features, you should think of this group of disorders. They also have renal manifestations, proximal and distal tubular disease. They can have neurological manifestations and visual problems, and then they have endocrine gonadal dysfunction, including external genitalia, can be abnormal, as well as problems with hypergonadotrophic hypogonadism. This is just a list of all the manifestations they have. And then, unfortunately, this is a condition that does not have a specific treatment, but the treatment is supportive. So because the glutathione is low, you give them N-acetylcysteine to improve that. And then you also give them a liver transplant when there's a liver failure. And I have not read about the outcomes like longstanding in terms of patients who receive liver transplant after this disease. And these are the metabolites that accumulate in these patients. So you have to ask for polyols. So that's the test that you are looking for, is urine polyols. And as you see here, there's a list of them: erythritol, ribitol, erythritol, with all the names. And there's a range of elevation that will occur in these patients that are significant. Sometimes you can see non-specific elevations, but the ranges in the patients who have the real disease are quite high. And I'll stop there for any questions. Thanks.
Thank you, Arig. That was really, really good. Very comprehensive, but awesome. I mean, it's a lot of disorders you covered in a short period of time. So there were some questions that came through on the chat, and I want to open it up to anybody else who might have questions first, fellows for Dr. ElGharbawy, before I ask them, because I think most of them were faculty. So anybody have any questions for Arig?
I'm sorry, it's a lot of information. And if I've made any confusion with the galactose, just let me know, and I'm happy to send you the information.
So the questions that came through on the chat, Dr. El-Beshri asked if for PDH deficiency, if triheptanoin has been looked at in terms of effectiveness in supplementing those kids.
No, PDH, no. Pyruvate carboxylase, yes.
Okay.
So pyruvate dehydrogenase, not. I mean, definitely, because there was a standard of care to give a ketogenic diet, it was never used in those patients. Now, if you say, can it be added like MCT? The point is MCT is added to the ketogenic diet to maintain the, ketogenic potential. So yes, I mean, think about it. It would help probably, but it's too expensive, and I don't think anyone has used it.
Yeah, and I'm curious if there are research studies that are in the works for that.
Yeah, you never know. You never know. Yeah. But definitely it's the same. I mean, if you think about it, it has a potential of breaking down into ketone bodies, so it can do that. And it can reach the brain. I mean, it is one thing, but I don't know that anyone has tried it.
Dr. Mori asked about biomarkers for newborn screening for HFI, if those exist. And
unfortunately not. So HFI is, again, one of those conditions where it's exposure to something and there's no newborn screen to it, because simply they're non-specific. So if you think about it, they develop liver failure. So you might see manifestations or biochemical abnormalities associated with the liver, but nothing like, there's no specific biomarker for it. There's not a specific analyte that is increased that you can say, I can use that for newborn screening. So you have to choose to screen for newborn screening, a screen that is specific for the disease, that when you have a cutoff value, it will determine that disease and not too many others with it. So it doesn't have that biomarker.
Dr. Murkowski is wondering about transferins in that setting. Transferins, serum transferins as biomarkers for HFI or
serum the isoelectric focusing of transferrin.
Yeah.
Well, it will occur when the liver disease happens. I mean, so be aware that isoelectric focusing of transferrin is happening when the liver disease is there. So if you do it in between for those patients who had it when their liver was in failure, you're not going to see it. That pattern is not there when they're normal. It's It's only there when the liver disease is there. And just to give you a heads up, alcoholism can lead to that as well. Liver cirrhosis can lead to that as well. So any patient who has liver disease can have an abnormal isoelectric focusing pattern. So it's not specific for HFI.
Yeah, unfortunately. And you brought up a very good point that more and more we're seeing fructose containing products and infant formulas. And we've had early presentations of HFI that were not on our radar because we didn't think that it was the right age for presentation. But sure enough, we've experienced it. We've talked to David Dimmick, who's seen whole genomes sent that have picked it up because it just wasn't on people's radar because the child was so young. There was at least one paper published by Dr. McCandless and his group when he was back in Cleveland that touched on that too. So it's a real issue, and it's something practically that you need to keep in your differential for kids that are under 6 months old, kids that are still formula fed, that they could be exposed to fructose without anybody knowing it.
Yeah, and we've had two by that. I mean, yeah. So I'm very cautious about it when it comes to acute liver, failure in a neonate even.
Mhm.
If they're on a formula, you have to look at it.
Absolutely. One last question that I had, and I was hoping you could touch on it a little bit more. What are your feelings? And I know you were very politically correct about talking about Duarte and treatment. It is still somewhat controversial, but I feel like there's been some good articles that have come out recently that have really supported not treating for Duarte. How do you approach it practically?
Yeah, if it's Duarte, I don't treat, to
Yeah.
be honest with you. If it is Duarte with the classic mutation that, glutamine to arginine, the classic one, I worry about that one a bit more, just when they're younger. But I do tell the family that, we could try after 6 months, we could try after a year. And if there's no harm, then I take them off. I mean, there's no harm in being cautious. With the African American variety, it's one of those clinical variant ones, but it's less severe. So that one I might be less concerned about it. But to be honest with you, with the more severe type mutation, I kind of keep them for at least 6 months, under observation, and then decide what we can do next.
Yeah. Good.
But that's for are you saying like even breastfeeding is contraindicated for those DGs? Like there isn't enough literature out there to support it, right?
About what, Shabani? Sorry.
Like DG, you're saying you would restrict them till 6 months of age, but what about if those kids could be breastfed? Because benefits of breastfeeding are much more.
So what I do, to be honest with you, since you brought that up, I give them half and half. If mom says, I want to breastfeed, and she's, interested in it, and then we see how they do with it. I mean, that's another way to see how, when they're challenged, how they do. So I sometimes will give half and half. I mean, it really depends on, the patient as well as the child and the parents. Some of the parents are concerned, they're the ones that want to wait. So we have to kind of keep that into mind as well. But yeah, I would do that. I mean, if there's a concern, we could, if you want to do that, you can do that. You can give breast milk, and maybe half breast, half soy, and see how things are going. Or if you just feel comfortable with giving the breast milk and seeing how things are going, that's fine as well. I mean, it really depends on how, what your experience is with it and your level of comfort.
And the family.
But there aren't any comparative long-term data, right? Outcomes data, right?
Unfortunately not.
Okay.
Well, thank you very much. Thank you for your time. Any other questions? Yeah, go ahead.
Thank you, Rig, for your talk. Speaking of galactosemia, I know that a lot of adults just disappear from our radar when they grow up, even if they were controlled previously. But I'm wondering what things we should look at besides females with infertility or DEXA scans in terms of defective glycosylation and whether there's endocrine issues or neurodegenerative issues when they grow up. How frequent or should we look there?
Well, the adults are, again, a group of patients that require special demands and special care. So those patients, they tend to have the apraxia and so forth, but they will come to you asking about potential fertility issues and things like that. So the question is, what type of mutation does the patient have? And I want to say preceding the adulthood, the adolescent period of time where they treated with, again, hormonal therapy or not. So these patients, they have streak ovaries. The estrogen levels are not appropriate. You have to give them treatment, from puberty and before puberty to make sure that they're maintained. So all of those things are things that you have to kind of look into them. So their bone metabolism status, because of the risk that they have these streak ovaries, and they're, are they on hormones or not? So they should be supplemented. Endocrine should be involved with these patients early on. And if they're not, if you're seeing them for the first time, or they fell from the radar, you need to make sure to redirect them to that avenue. And, again, these patients require estrogen because of the streak ovaries, which is going to be important for the cognitive, other than the bone metabolism, the cognitive part. So it's important there. But then think about it this way. They tend to have speech apraxia. They tend to have some neurological manifestations. So you want neurology to assess them. You may want to see if you see something that is, worse about the patients, like in their history, they were doing something and now they're not able to. You do want to do imaging of the brain and see what's going on, but you really can't. You can't do much more other than that. I mean, in the adult patients, what happened, and you're just looking at the sequela of these patients, like what are they doing now? So a general overall assessment, looking at their neurological status, tremors. So abnormal movements is one of the big things. If they've got any problems with instability of their gait, they can have, ataxia and things like that. You want to check imaging in that case and have neurology evaluate them. The other thing is, again, fertility status. If they're coming to you asking for that, what type of mutation do they have? The African-American variant is not one that's associated with significant problems with fertility. They can actually become fertile. It's that common mutation that is associated. And I've seen case reports where even they have become pregnant. So, just look into the matter as, why are they coming to you and what are they asking for? And in terms of their metabolic control, how well are they doing that? And if they're not doing it well, what complications are associated with it? So we know it can be neurological. We know it can be associated with, some speech issues and cognitive issues that are there. And, you just have to follow them and see what's going on, bone problems, things like that.
Thank you.
Yeah,
Thank
I
you.
mean, the adult is a reflection of what happened earlier, but you want to make sure that if you see them as an adult, that they're getting all what they need. That's the main thing. And make sure if they have complications, they're provided the services that they need in order to be able to, do better, have a better quality of life.
Mhm. Thank you, Dr. ElGharbawy. We really appreciate your time, and thank you for covering such large amount of material in a shorter period of time. Thank you.
Yeah,
And,
I tried.
yeah, no, you did very well.
That's good.
We will return next week with Dr. Wilcox, and everybody have a good weekend. Thank you.
All right, take care. Thank you. Bye.